hold on.
Yeah.
Let me try this. Let me try it now.
I couldn't get the word.
Test, test. How about that? Because I just unmuted myself.
Very good. Good morning, everybody. We will go ahead and call today's Healthcare Commission meeting to order, the February 16th, 2024 Healthcare Commission. We will start by taking roll. Commissioner Schmidt.
Here.
Commissioner Deckent. Okay, what I'm hearing is Commissioner Deckent is online. We're working on technical difficulties to allow him to speak. We will let the minutes reflect that he is there, and we'll continue to work. Commissioner Kane.
Here.
Commissioner McGinn. Commissioner Hensley.
Here.
Commissioner Landwehr. And chair is here. We have a quorum, so we will go ahead and get moving. I think our legislative members might have some legislative commitments this morning, so we'll keep an eye out to see if and when they join. Commissioners, your packets were emailed to you earlier this week or late last week. In there were the minutes. So first item on the agenda is to review the minutes. Are there any requested edits for the minutes? Commissioner Schmidt.
Thank you, Mr. Chairman. My name's just spelled wrong.
Oh, well,
Thank you.
we should fix that. Any other edits to the minutes? Hearing none, I would entertain a motion to approve
So moved,
as amended.
as amended.
As amended, we have a motion by Commissioner Hensley. A second?
Second.
Second by Commissioner Schmidt. All in favor, say aye.
Aye.
Any opposed? Motion carries. Minutes are approved as amended. All righty. Commission, we have a couple of contracts to review the results of the RFP and to make a recommendation on which way to move forward. The first one is going to be in tab 2 of your books for the COBRA administration. And I believe Director Flory is going to walk us through the RFPs that we received and give us some information here. So Director Flory.
Okay, Pete, go ahead and move forward. One more. Okay. The Consolidated Omnibus Budget Reconciliation Act, better known as COBRA, is a requirement for employers to offer to workers that lose coverage. COBRA allows members to continue their group health insurance product by paying the premiums directly, depending on the reason for the loss of coverage. That may be for either 18 or 36 months. So for our COBRA program for the state employee health plan, we do outsource this. The administration of this is done by an outside vendor that is responsible for sending out those notices as well as collecting the premiums. They work on the open enrollment. So this year that contract is out for bid. And on the next slide, you'll see that we did receive 2 bids. Our current vendor is Itedium. They are located in the Kansas City area, and they offer our COBRA administration today. Total Administrative Services Corp, better known as TASK, that is our prior incumbent in this space. So both of these providers have provided the COBRA administration services on behalf of the state. And so we took both of those bids into the finalist round. On the next slide, we looked at the bids. We determined where the vendor is able to provide the services being requested. Do they have experience providing COBRA to similar size group, which they both do. They've both done it for the state. We looked at the services provided to the members as well as to the state employee health plan staff, the reporting, the cost of the services. On the next slide, some of the services that are included in this bid is, of course, issuing out those all-important COBRA notices and member communications. They manage the premium payments, reporting. They offer a member portal where members can go in and they can elect to pay their premiums direct through not payroll deduction, but through bank drafts. They also have a portal for the state employee health plan to use to go in and to manage the coverage. And they remit the premiums then back to the state employee health plan. And on the next slide, again, we go over a little, it's kind of what I just went over. You know, some of this, what that means, initial notices are the rights that a member has as someone who is leaving the state or losing coverage under the state, what those rights are outlined in those notices. They send the termination notices when the period of time that they're eligible for has elapsed or if they fail to make their premiums. They participate in the open enrollment process, providing access and information to our COBRA members on the open enrollment. On the next slide, we have the first of the yearly cost comparisons. So in this space, we find that sometimes vendors prefer to bid based on the number of activities they do versus based on an overall population number. So in this particular breakdown, this is the comparison of ITDM's price versus task price if they were to bill us on a set number of services. The number of services is listed in the second column. Those are based upon the numbers for plan year 2023. Compared to the rates that they have proposed to come up with the annual cost and then the 3-year cost. On the next slide, we have the same two vendors compared, but this time it's based upon just a number of individuals that we have covered under the plan and a flat fee per individual. And in this comparison, then you have ITDM again and task, and the numbers are based upon our current enrollment. So the math is just the number of individuals that have to get open enrollment packets. We use the number from plan year 2023 to come up with that to show you the cost comparison between the two companies. And with that, I will stand for questions.
Very good. Pardon me. Thank you for the review. Commissioners, any questions? Commissioner Schmidt?
Thank you, Mr. Chairman. Vicki Schmidt. So what is the, do we have a choice then of how we contract with them on the number of, based on the number of employees or based on the administrative fee billed based on our count?
Yes, they bid both ways and the state can select which one they choose to have.
And what did we select on the previous 3 years? Did we, which way did we go the previous 3 years?
Was it per member? It was per member, which is the second one.
The second one?
Mm-hmm.
And can you tell us on the 3-year history of the number on the per COBRA participant?
I don't have that information now. Generally, our COBRA participation has been in the 250 to 300 range. With the changes made last August, though, that number is likely to go down because more individuals who are retiring will move directly from active to direct bill as opposed to stopping in COBRA. And we had about 120 folks last year at the end of the year that were on COBRA that moved to direct bill. So we anticipate the number will be lower in future years than it has been in the past because of that change, but I don't know the exact 3-year history of how many exact members we had. It's kind of a point in time. It changes as people come and go. Individuals may elect COBRA for 1 or 2 months because they're in between jobs. Other members may play the system and say, oh, well, you have a 60 days to decide. I'm going to wait and see if I get a job before I actually take the COBRA. So the numbers do fluctuate between year to year.
Well, I think with the changes that were made that allow the early retirees to not go to COBRA and to do the direct bill, I think it would make more sense to do it based on the per COBRA participant, but that's just my opinion.
And the commission has the option to choose that if that's what you so direct us to do.
Very good. Any other questions? We're hearing some background noise online, so I don't know if that's Commissioner Decken or if we're okay.
Yeah, yes, it is. You can't hear me, I take it?
Yes, sir.
Okay, good.
Any other questions on the comparison of the plans? Hearing none, I think we're at the point where we would entertain a motion. Commissioner Schmidt.
Thank you, Mr. Chairman. I would make a motion to contract with ITDM for, I think it's 3 years. It's a 3-year contract, and to use the to contract with them on the per Cobra, by the per Cobra participant of $650 per month.
Council, do we have what we need in terms of making sure that's clear in the minutes?
Yeah, and that would be the one that the annual cost is projected to be $87,250, correct?
Yes.
Okay, very good. You've heard the motion. Is there a second?
I second it.
Second, Commissioner Hensley. Any discussion? Hearing none, we'll do a roll call vote. Commissioner Schmidt,
Aye.
Commissioner Deckett,
Aye.
Commissioner Kane,
Aye.
Commissioner McGinn, Commissioner Hensley,
Aye.
Commissioner Landwehr. Okay, I see 4 votes, so that motion should carry. All right, very good. Motion carries. Moving right along to action item number 3, we have another contract to review, RFP to review. I think this one will be a little bit more lengthy. This is on the health reimbursement and health savings account administration contracts. Director Flory, I believe you're going to walk us through this again.
Next slide, Pete. So this contract would be for administrative services for our health reimbursement accounts and our health savings accounts. Health reimbursement accounts are tax-approved, employer-funded accounts that individuals can use to reimburse out-of-pocket expenses for medical, dental, pharmacy, et cetera type claims. The other account is a health savings account. With a health savings account, in order to be eligible to put for an employee to deposit funds into a health savings account, they have to be enrolled in a qualified high deductible health plan. That health plan must meet all of the IRS requirements to earn that designation of qualified high deductible health plan. And when they do, then the members who elect that, as long as they are not Medicare eligible, and there are a few other disqualifiers, but for the most part, the majority of our employees on the high deductible health plans have selected a health savings account, which is a tax advantaged bank account that they own. They can contribute to it, and the employer can contribute funds into that account. The HRA differs in that it is only employer money that goes into that account. Employees may not direct funds into the HRA. And at the end of the allowed period, those funds do roll back to the state. So on the next slide, we took this out for bid. We do have a 3-year contract, and so our contract will be up at the end of the year. We received 5 bids. Of those 5 bids, we took 4 of them into the final rounds of negotiations. On the next slide, we look at some of the factors we were thinking about as we reviewed these bids. We were looking for what services were provided to the state employee health plan and to our members. We were looking at the cost of the accounts and the fees that were going to be assessed. On a health reimbursement account, the fees are paid by the state because those are state-owned accounts. On a HSA, those are employee-owned accounts, and so any fees assessed on those would go to the members. So we were looking at those and the options that were offered. You know, what type of options did they have as far as investments for those HSAs, what the criteria was for investing, what were the thresholds. So there's a variety of things that we looked at going into that. So on the next slide, some of the services that we were looking at was what type of reporting would the vendor be able to provide. Because there is an interface with payroll on those HSA dollars, it's important that we be able to get accurate information, that they handle our reports in a timely fashion to ensure that members' money flows to their checks in a timely manner. We were looking at the member portal. How easy was it to navigate? What services were available? What could a member do on the portal? What could the employer, the state employee health plan, what options were available to us on the staff portal to be able to review information, access reporting, and that type of thing. We also looked at what type of communications and educational materials the vendors were providing to our members. So on the next slide, we jump into pricing. We start with HSA pricing. The HSA, again, this is all employee money as far as fees. Any fee would be paid by the employee, not by the state. We had the 4 bidders that we took into the finalist round were Central Bank. They're located in Missouri. They partner with ASI Flex. So ASI Flex is a prior flexible spending account provider that the state has done business with. They partnered as ASI Flex with Central Bank in doing that flexible spending account. So we do have experience with them and their ability to offer services and to provide them to our members. MetLife is our current incumbent. They've been providing the HSA and HRA services for the last 3 years. New Synergy is our prior incumbent vendor that has offered services in the HRA, HSA space to the state. And we did have Optum. It's been a number of years ago, but we originally had a contract with, what was the bank? US Bank, and US Bank sold that contract to Optum. And so for a period of time, we did have Optum as a vendor. So we know all 4 of these vendors have the capacity to provide the services being requested in the RFP and to do the health savings accounts. You'll see with Central Bank, MetLife, and Optum, there is no monthly fees on the accounts. However, when we get to a later slide, we will disclose there are some fees under the Optum contract for other services that a member might encounter on an HSA. With New Synergy, there would be a 45-cent account fee per month that the employees would pay, and we've shown you the cost of that, what that would be for a year based on our current number of members with health savings accounts, which is over 20,000. On the next slide, we're going to go over the HRA. Again, this is the employer side account. The fees here would flow to the state. We have far fewer HRAs. With that, we have currently about 1,674, and you'll see that Central Bank, MetLife, and Optum are quoting no fees to the state for providing that HRA service. New Synergy is quoting a fee of $1.45 for those accounts per month. You'll see then the annual cost of that fee and the 3-year cost of that fee. So on the next slide, we go over some additional information. MetLife is our incumbent. They have been administering our HRA, HSA for the last 3 years. MetLife and Central Bank's offers both include no member costs for their HSA account, regardless of the member's account balance, and there are no charges for other services they might offer, like paper statements, use of an ATM, etc. New Synergy has fees on both the HSA and the HRA, along with other fees for return checks, paper statements, and account closure fees. Optum, while they have no monthly fees for the HSA or HRA account, they do have fees for some other services, which include an account closure fee, an ATM fee, and a paper statement fee. And with that, I'd be happy to answer any questions.
Very good. Thank you for the review. I do have a question. With MetLife as our current incumbent, is that correct?
Yes.
And they have no monthly fees, as you stated back on slide 23 in my book, slides 23 and 24. Do they currently have account closure fees or transfer fees or anything? So if they were not to be the successful bidder, are there fees associated with that?
No, there are not.
Okay, thank you. All right, commissioners, any other questions? Commissioner Schmidt?
I don't have a question, but I do think there is, after talking with some of my employees that do have HRAs and I'm sorry, HSAs, the HRAs would just affect the state, but that have HSAs, I think that with the MetLife and Central Life both offering 0 on the monthly fee per account and certainly the additional fees, I think that the preference of the people that I have spoken with would be to stay with the current vendor just for ease of the accounting process, and it would be just no change for them. So I would make a motion to continue the 3-year HRA and HSA administrative contract with MetLife.
All right, commissioners, you've heard the motion. Is there a second?
This is Steve Deckent, I second.
All right, we have a second by Commissioner Deckent. Any discussion on the motion? Again, the motion is to extend the contract with MetLife for 3 years, who is the current vendor. Any discussion? Hearing none, we'll do roll call vote again. Commissioner Schmidt?
Aye.
Commissioner Deckent?
Aye.
Commissioner Kane?
Aye.
Commissioner McGinn, Commissioner Hensley,
Aye.
Commissioner Landwehr. Okay, I'm again showing 4 affirmative, and I'm getting a thumbs up from council. Motion carries. Thank you very much. All right, Commission, that concludes the action item portion of our meeting today. We will move on to the equally as important reports section. So we're going to move into tab 4, which is a more in-depth review of the open enrollment report. As a reminder, this report was emailed around to the Commission, I believe, about a week before it was submitted to the legislature. We did get it to the legislature by the deadline that's in statute, which is the day that the governor's budget is released. So I'm just going to do a more in-depth review, and Director Flory is going to walk us through this. And if we have any questions, we can certainly have her answer those. So Director Flory.
So we're going to go through the open enrollment summary that will provide the commission with information about where employees landed during the most recent open enrollment that occurred in October. So if we move forward, Pete, we're going to start with the active employees. So you can see that 34,261 or 87% of state employees elected to enroll in a health plan. We did have 5,126 who elected to waive their coverage. On our non-state public employers, we had 3,524 enroll, with 332 of our non-state public employees deciding to waive coverage. Plan A had the highest enrollment with 18,558, while followed very closely by Plan C with 15,788. Plan J, again, as a reminder to the commissioners, Plan J is designed specifically to address the needs of anyone in this country on a J1 visa. It is available to any employee who wishes to enroll, but because of that particular plan design, it tends not to be as popular because it tends to have a little bit higher cost to meet those deductible requirements. Plan N is our other high deductible health plan that is available to employees. This is our low cost plan, and we had 2,799 of our employees elect to take that. On the next slide, we break it down between Blue Cross and Aetna. So you can see that Aetna has 3,554 of those contracts. Blue Cross has 34,231. Those are the TPAs that provide the services on behalf of the state to administer those programs. On the next slide, you always like to know how many people switch between Blue Cross to Aetna or Aetna to Blue Cross, and you can see the number is pretty consistent. 295 went from Aetna to Blue Cross, and 303 went from Blue Cross to Aetna. On the next slide, we break it down further with regard to our different plans. We show you on Plan A, C, J, and N how many of those individuals elected the Blue Cross option versus the Aetna option. So again, on the next slide.
Actually, I'm sorry
Okay.
to interrupt. Just to hit the pause button, just so we're clear, these are the 37,785. That is number of contracts, not number of lives. Okay.
Contracts.
So the number of covered lives is greater than that.
Yes.
Okay, very good.
Yes.
Thank you.
These are contracts. We're going to get into on the next slide, we're going to start looking at more information about the coverage. So these again are contracts. These overwhelmingly, as has always been the case as long as I've worked for the health plan, employee only coverage dominates with 20,818 individuals selecting to have single only coverage. Employee children is the next most popular option, with family, and followed by at the bottom employee spouse coverage with 4,207 contracts. And then on the next slide, we're going to break down those dependents even further so you can see. Total state dependents is 31,383. Of that 31,000, 8,355 of those are spouses, and 23,028 are children. And we also provide you that same breakdown for our non-state public employers. They have 874 spouses and 2,385 children. And then down at the bottom, we show you the total that we have 9,229 spouses and 25,413 children covered. So those are lives that add to the contracts. On the next slide, we go through some of our optional plans, and Pete, this isn't the most current version, so we had a problem when we converted our slides from a PowerPoint over to the packet, and the headers dropped off. So Dental, we have 38,402 individuals that elected to enroll in a dental plan. The commission will remember a few years ago, we split dental from medical, so you can select dental only if that's all you wish to purchase. It should have a header right above where it says basic plan that says prescription eyewear insurance coverage. There are 32,113 individuals who have elected to enroll in one of the voluntary prescription eyewear coverage plans. The enhanced plan was the most popular, was 23,177 contracts. The basic plan has 8,936. We will send out a corrected deck to the commissioners because this one is missing headers. On the voluntary insurance side, these are all employee paid dollars on the voluntary insurance, as is the eyewear coverage. Accidental injury was the most popular option. We did go with our new vendor this year. Remember, all employees had to go out and actively elect voluntary insurance if they wanted to be enrolled, since we moved from Hartford to MetLife. 15,146 of those elected to do that and take accidental injury coverage. Below, you'll see the critical illness. There are two options available, and we had over 10,000 employees elect one of the critical illness policies. And then on hospital indemnity, we had 11,134 that made an election. Again, there are two options, a $10,000 option or a $20,000 option, and employees selected between those as they made their election. Those, again, are all employee paid dollars. On the next slide, again, we're missing a header. Over there on the right, it should say health accounts. There are 18,604 health accounts. These are the account-based enrollments. Of those, 16,908 are health savings accounts. 1,696 are health reimbursement accounts. Again, that is the least selected option, but again, it is a necessary option for individuals who are Medicare eligible, have TRICARE coverage. They are only eligible to take the HRA because those are qualifiers for rolling in an HSA. On the flexible spending account, again, this is an employee option. The medical flexible spending accounts can be used by members on Plan A, Plan J, or if you are on Plan C or N and have an HRA, you could enroll in a medical flexible spending account. This allows you to set aside pre-tax dollars to pay for your unreimbursed medical, prescription drug, or dental expenses. The limited purpose FSA is for our individuals who are on an HSA. Because they have an HSA, they are not allowed to set aside pre-tax funds for additional medical expenses, but they can set aside additional pre-tax dollars to use for vision or dental expenses. The dependent care account, that flexible spending account, is for child care or adult daycare expenses. And we have 1,585 individuals who have elected to enroll in a dependent care flexible spending account. And the commuter benefit was new last year. This is an option. There are two options within this. You can take a parking benefit. Parking would allow you to set aside funds pre-tax to pay for parking outside of a state-run facility, because the state in some campuses do charge for parking, but they already have a pre-tax version of that, like at the University of Kansas and the University of Kansas Medical Center. This would be for individuals like myself who I park in a city-owned parking lot and pay that fee out of my pocket. I can set aside funds to pay for my parking using this parking account. Mass transit allows individuals to set aside funds to pay for public transportation, such as a bus or the state van pool. And we have 69 individuals who have elected to do that. On the next slide, individuals who failed during this open enrollment to make an election, the Healthcare Commission had set up an option. If an individual was enrolled in medical insurance during plan year 2023 and during the 31 days of open enrollment, they did not go out and make an election, they were defaulted to Plan N with an HRA. The reasoning being that Plan N is our least expensive program, so we are not committing more of our employee dollars than necessary. And the health reimbursement account, again, because those are all employer dollars and we are not obligating our employees to additional expenses. This year, we had 450 individuals who fell into that category. Of those individuals, 408 of them were state employees and 42 of them were our non-state public employees. 147 of that 450 were already enrolled in Plan N during calendar year 2023 anyway. So those individuals did get moved to Plan N for next year. If they were enrolled in Blue Cross in 23, we moved them to Blue Cross with Plan N in 24. They had Aetna, they stayed with Aetna. So we do keep them at the same coverage tier with the same vendor. We just move them to Plan N so we ensure that they do have coverage for the following year.
Jennifer,
Yeah.
Steve Deckett here. Was there any pushback or comment or from any of those 450 people?
I'm only aware of us being contacted by one individual, and we were able to, we could not move them out of Plan N because the plan year had already started, but we did move them to an HSA so that they could set aside some funds pre-tax to help pay for the deductible. The person was on a plan that was more expensive, so they were able to set aside those funds, the reduction in premium, into an HSA to use for their healthcare expenses.
Okay, just one. Okay, thank you.
That's the only one I'm aware of. There could have been others, but to my knowledge, that was the only one that I was aware of.
Commissioner
right.
Schmidt, you had a question?
Yes, thank you. So I know you said if they were in Aetna or Blue Cross, you kept them in that, but if they were not, how did you decide which they were going to go to?
So you have to have had coverage in Plan Year 23. You had to have enrolled and been covered under Plan A, C, J, or N in 23 to be defaulted. If you waived coverage in Plan Year 23, your waived would remain in place until you actively go in during an enrollment and enroll. So if you didn't have medical coverage, we did not enroll you in medical coverage. We just ensured that if you did, that you didn't lose.
So let me make sure I understand that. So if an individual waives coverage in 2022, it remains waived without any action, and so we don't really. Okay.
Yeah, you're
Right.
correct. They stay waived until they go in and take an action to say, I want coverage.
Okay.
So,
All right. So they don't have to do that every year.
no,
Okay.
it just rolls from year to year.
Okay. Thank you.
Any other questions while we're paused? Okay, go ahead.
Okay, we're going to move on to our direct bill open enrollment. And so direct bill open enrollment it's offset from the active. It starts on October 16th and it runs through November 15th. We do bring in a call center. They are individuals who are former state employees. Many of them are had HR backgrounds to come in and answer the phones so that our individuals who are out there and not able to they can't enroll themselves in MAP. If they choose not to, they can call and we will help them get enrolled with our call center. So it's an option for our direct bill members. This group of direct bill members that we're looking at, these are the ones that are enrolled under the non-Medicare programs, which we refer to as the active and plan. Of those, we have 106 that are in Plan A, 175 on Plan C, 3 on Plan J, and 5 on Plan N. Let's move to the next slide. So this one, we're looking at our direct bill members who have Medicare coverage. So the header is missing on the right-hand side. At least it's on the left-hand side. The header on that should read Medicare Supplement Insurance. And we have 7,093 individuals who are covered under one of the state's Medicare supplement plans. Kansas Senior Plan C and Senior Plan C Select. These are plan options that, due to changes in the requirements that the federal government has, they are no longer open blocks. Individuals cannot, newly eligible Medicare people cannot enroll in Plan C or Plan C Select, but individuals who are already enrolled in those may keep them for as long as they like. The difference being that the newer plans like Plan G and Plan N do not cover the Part B deductible, and Plan C does. But there is a requirement now under CMS that we cannot offer that to newly eligible Medicare members. The select option you see, the difference between Senior Plan C and Senior Plan C Select is in certain select markets. If you enroll in that program, you are limited to a specific hospital in a non-emergency situation. So that's the difference between Plan C and Plan C Select. So for our individuals enrolling today, they can choose Kansas Senior Plan G, Senior Plan G Select, or Senior Plan N. Individuals in this market do not have to make an active election each year. Their coverage will roll from year to year. So unless they choose to make a different election, we do not require them to enroll. We also offer Medicare Advantage programs. We've offered these for a number of years, and while the enrollment number isn't super large, it has grown over the years, and we're now up to 831 contracts. This is available through Aetna. It's the Advantage Freedom PPO and the Advantage Elite PPO. These programs include both the medical coverage as well as the Medicare Part D coverage is automatically included for those individuals. On the Medicare supplement side, those individuals do not automatically have prescription drug coverage with us. So go ahead.
Commissioner Schmidt.
Thank you, Mr. Chairman, Vicki Schmidt. So I just wanted to make sure that I understand this correctly. If you were to elect to go from a G to an N, though, you have to go through underwriting if it's not the first time.
Not with us, you do not.
You do not?
No. During open enrollment, if a person wanted to move from Plan G to Plan N, they would be allowed to do so.
Because in the open market, they have to go through underwriting.
Yeah, there are some advantages in our Medicare plan. It is not age rated is another difference between us and the open market. So as you age, your premium does not go up because you age. But for our individuals who are just becoming Medicare eligible, our rate may be a little bit higher.
Right.
And the break-even point, I believe DeLoss told me, is it 71? It's 71. At age 71, our plan starts to become cheaper than the open market because we are not age rated.
So 6 years.
Mhm.
Okay, thank you.
Any other questions while we're paused? Okay, go ahead.
On the next slide, we're looking at the dental enrollment again. Individuals who are in the direct bill program, if they want dental, they have to enroll in that. When they retire, they're allowed to continue that optional dental coverage as long as they like. They can also elect only to pick dental if they don't want to take our medical insurance and buy it in the open market. They're free to do so and just take dental with us. We have 8,241 enrolled in the dental. Over on the right-hand side, the header should read prescription eyewear insurance, and we have 5,549 of our direct bill participants who have elected to enroll in one of the voluntary eyewear prescription coverage plans. With this population, again, the enhanced plan is more popular with 4,547 enrolled in it versus just about 1,000 in the basic plan. The big difference is kind of obvious why they would pick the enhanced plan, because the enhanced plan covers your no-line bifocals and has a higher benefit for that. So it's going to be more popular with an older population. Okay, on the next slide, we should have our this is our Medicare prescription drug coverage, our Medicare Part D enrollment. The header here should read SilverScript Part D. We have 1,953 individuals who have elected to enroll in the state's Medicare Part D prescription drug plan. This is an optional program, so if I take a Medicare supplement policy through the state and I wish to enroll in Part D coverage available in the open market, you are allowed to do that. They do not have to take the state's prescription drug coverage if they don't wish to. With our plans, we offer two. Our Premier plan has always been a little more enhanced version than what's available in the open market. And you can see that clearly it's more popular with 1,543 members selecting the Premier. The economy plan we brought in a couple years ago, it's more in line with what's available in the private market. It's a lot less expensive. It has gained popularity over the last couple years with now up to 410 contracts. And with that, I will be able to answer questions. In the back in the appendix, though, we have provided just for your reference, we've given you like 5 years So you can see what did Plan C's enrollment look like over the last 5 years? How did it break out between Aetna and Blue Cross? We have the number of waves. All of that detailed information is in the back.
Very good. Thank you very much, Jennifer. Appreciate the review there. And yes, commissioners, there's a whole host of detail in the back. I've thumbed through quite a bit of it, and there's good information. One thing that stuck out to me was on either slide 26 or 51, depending on which side you're looking at. 26 of this section, employees who did not actively make an election 2020 through 2024. You can see that the numbers are substantially lower this year than last year, and there's been a downward trend from 2020 through 2024. So it feels like we're making the outreach to employees and getting a better uptake rate, which is good news as a commission, and that's our goal, to have a broad reach and make sure that folks have access to it. Any questions or comments before we move off of this report? There was a lot to take in there. I will take, Commissioner Schmidt.
I would just say, if you send us the slides with the headers, could you just send us the slides with the headers and not the whole packet again?
Your secretary already has the whole deck. I sent it to her yesterday because I knew you printed your own. So she was going to replace it in your book.
Yeah, I got some of those replacements, but not all of them.
If
Well,
we can parse out just section 4, let's go ahead and parse that out and resend it to the commissioner if we
Yeah.
could, please.
Okay,
Thank you.
thank you.
Any other questions? And I'll mark this as a comeback item if anybody has anything that pops into their head as we move through the agenda here. So, okay, seeing nothing further at the moment. Thank you, Director Flory, for your reports and recommendations. They're not recommendations, but your reports and council. We are going to move on to item number 5, which is a benchmark study that we've asked our friends from Siegel to do. So if you can come to the mic, introduce yourself, and commissioners, we are on tab 5.
Let's try that again. Patrick Klein with Siegel. Good morning. Okay. So the purpose of the benchmark study is to compare the Kansas plan with other state health plans. The focus, we're really focused on the plan design and the cost components of the plans and their comparisons. And we actually did the same study, more or less the same study 4 years ago. So it's interesting to see how the results have changed. And, you know, a lot of that has to do with the decisions that have been made over the last 4 years. And you'll see some improvements on, you know, how the Kansas plans stack up against some of the competition. And we have a larger deck that's, most of the slides are in the appendix. So that's a little too detailed for today. So we're just kind of focus on an executive summary. But if there's any questions on other slides, I'm happy to walk through those. Right. Given that over 90% of the enrollments in Plan A and C, those are the 2 plans that we're focused on. Plan A, we have comparisons against PPOs nationally and regionally. Plan C, we're looking at high deductible plans, consumer health plans. The regional states that we chose, these are the same as the last presentation. So we have 5 neighboring states, and we're looking at medical and pharmacy. And again, the key pieces that we're looking at are the plan design, all the various components, deductibles, copays, out-of-pocket maxes. So, you know, any cost sharing on the different plan designs for medical and pharmacy, and then what they pay for the design, you know, who pays for it, what's the employee contribution, the employer contribution. The Kansas and regional state information is as current as possible, and the national data comes from our 2023 Siegel State Employee Benefits Study, and there is some information where we needed to leverage the 2018 study and trend that forward. So here's kind of a map of the plans that we're comparing against your neighboring states and their various plan designs. I won't go into too much detail here, but it looks like, you know, Missouri and Nebraska have similar structures as Kansas. So you have a PPO and then you have a high deductible option. Oklahoma and Colorado, they have more plans and they offer a decent amount of HMOs alongside those. And these abbreviations, you're going to see these on the next couple slides. So this is kind of a key for the graphs that we're going to show later on. Skip over the key findings. I don't want to spoil all the good information here. So this slide here is talking about what offerings in terms of the type of plan, you guys versus your comparison. So everybody offers a PPO. 4 of the 5 neighboring states offer a high deductible plan, and then 3 offer HMOs. And yeah, I think just working with different states and knowing about the national survey that I think it's more rare to have an HMO. It's usually pretty common to have a PPO and a high deductible option. So the next series of slides, they're all gonna be structured kind of the same way, where we have all these various regional plans that we're comparing against. The Kansas plans are in that light blue teal, and then the regional plans are in a darker shade there, darker shade of blue. So this first comparison is the actuarial value, and I know we talk about that quite a bit, but just as a refresher, that's measuring the percent that the plan picks up claims-wise through the plan. And so the complement of that, or so, you know, if it's an 80-20 plan, we're saying that the plan would pick up 80% of the claims, the member would pick up the remaining 20% through their deductible, coinsurance, copays. So the higher the actuarial value, the more beneficial to the member. So we also pulled in the actuarial value from 2020, so you can see how things have changed over time. And I know there's been a big focus on Plan A, lowering the deductible, lowering copays over the last 4 years. So you can see that that plan's actuarial value goes from 80% up to 85. So before it was definitely on the lower end of the spectrum here, and now it falls pretty much right in the middle. And Plan C, there hasn't been as many changes done there, but that's one of the most valuable plans that we're comparing against. And a lot of that has to do with that HSA funding. So any questions on the actuarial values?
Commissioner Schmidt?
Thank you. Are you going to go back to on page, I think it's 83 or 4, the key findings, that slide, like that last bullet point? Will you go back to that?
Yeah, I was going to wrap up with that.
Okay,
So
thank you.
Go ahead.
right, so now we're talking about total premium. So in theory, this should be the total revenue needed to cover the plan's cost. And the way that's broken up, the total rate, and then what the employee pays and what the employer pays. So you have so we have a stacked bar here where you can see that the full bar is the total premium. And then on the bottom, it's a little hard to see, but you can see what the employee piece is, and then the darker color is what the employer picks up. So over here for Plan A and C, your total rates or your total costs are a little bit higher than the benchmark plans. And we look at the contributions, these small little bars, I mean, it kind of bounces all over the place. So yours, Plan A, Plan C, the members are paying a little bit less for single coverage than Plan A. The employer piece, the bar is, the exact same length. So it's the same dollar amount for the employer side. But some plans, they're not charging any contribution. We have other plans here that charge higher contributions. So it's kind of all over the place, but the takeaway here is that your rates are a little bit higher, and part of that is that you have higher value plans. So we just saw that Plan C is a higher value plan, but this also has to do with like the underlying risk, your membership. So the allowed cost, this is for single coverage again, it takes the premium rates that we saw before, and then it adds in what the member pays out of pocket for their claims. So those are claims that never get seen by the plan since they're paid by the member. So this is a function of how rich the plan design is. So a lower AV plan or lower actuarial value plan, you should see more out-of-pocket claims. And why I like the slide is because it normalizes for plan design. So essentially, all of these are on 100% actuarial value. So you can really get at the risk or the underlying cost of the plan after you normalize for the plan design itself. And no surprise, Plan A is higher than Plan C. I think it's common that your riskier population, they like the idea of copays, and they're not going to be selecting a high deductible plan necessarily. This plan at the bottom here is a Nebraska high deductible plan. I actually work on the state of Nebraska, and I know for a fact that only 15% take that plan. There's no HSA seed. The only reason people take it is because you have it's the lowest contribution. So it's really for those young, invincible folks who think they're not going to use this system at all. So even though that their allowed cost is lower, but it's really a function. If you look at the average age of that plan versus Plan A, you're going to probably see like a 10-year difference. I'd say this is probably the most powerful slide in the deck because we're combining what the employee pays for the coverage, so through their contribution, and what they pay out of pocket for claims. So it's really combining. You can have a plan design where you only have a $100 deductible, a $10 copay, but if you're charging that person $1,000 a month for that plan, is it really valuable to them? So this combines the plan value and what they pay or through the contribution. So in one way, you could think it's a percentage. So in one way, it's what percentage of the total overall cost in the entire system is the employee paying through contributions and through claims. The complement to that is what we're showing here, which is everything they're not paying, the plan's picking up. So it's really the total employer or state subsidy is what we're showing here. So Plan C is looking, really Plan A and C are both somewhat in the middle of the pack, but Plan C does have more richness, and that's a function of a lower contribution and a higher value plan design. But it is nice to see that when I bring in the 2022 or the 2020 exhibits, you can see that there has been improvement in both A and C.
Commissioner Schmidt.
Thank you, Mr. Chairman. So I want to try to understand this a little. That's on the single plan only, right?
Yes.
And then the next one, we're going to go to the family.
Yeah, the family is a different story.
But why didn't we do it for the employee spouse and the employee children? Why didn't we do those also? Because I think that employee spouse would show a totally different picture.
It would. Yeah, that's a good point. Yeah, I don't know, we only had so many slides, and that's just kind of the direction that we've always went as we look at employee and family, but especially the way you have a flat employer subsidy for employee spouse and employee family, it's the same amount, which is unique. A lot of plans, it's staggered. So you wouldn't see that big difference. And if you looked at employee plus spouse and family, the story would be the same, but yours is going to be a little bit different. So I'm happy to rerun those numbers and bring in like an employee plus spouse comparison, but I think it was just, it's what we typically do.
I think it would be, I'm not asking for the whole slide deck to be that way, but I think on this richness plan, as we go into talking about plan design for the next year, I think it would be interesting to see that employee spouse and employee children. The other question I had was on the HSA side of on the Plan C side of it. Does there's a potential of the 50 points of the more employer contribution into that? Are the 50 points,
No,
is that included in this?
Yeah, that's a good point. So no, none of the wellness what can be earned is included in the comparison. It's tough with all the benchmark plans because they have their own smoker surcharges and different credits that people can earn, and we just don't know what percentage people are. So we try to keep everything on a base level. In the appendix, sorry, I'm flipping around here. We did bring in what the contribution is, so you can kind of see that $40 credit on the contribution side. But as far as these comparisons, and we didn't really know what the regional states were doing. We try to keep it apples to apples the best we can.
So in some ways, if a Plan C participant were to take advantage of all the 50 credits, that would increase the richness of that plan even more.
Yeah, absolutely.
And certainly the richness compared to a Plan A.
Absolutely, yeah.
Okay. All right.
May I piggyback off that? So is it fair to say that this is sort of the almost worst case scenario or most basic level of the richness and the others, and it only improves once you layer on the wellness factors?
So your plans would definitely, your richness would go up for anybody who's getting that wellness credit or HSA seed money. But then your neighboring states, they have their own wellness initiatives and smoker surcharges, so theirs could go up. So I don't know how much.
So
the
relative
ranking
to
would
other
change.
states would be tough, but in a standalone, simply looking at the state's
Yes.
richness percentage, we could articulate that this is the baseline and it only gets richer when you add the wellness.
Yes.
Forget
yes.
the relative to our peer states.
Mhm.
Thank you for that clarification.
Okay, so we'll switch over to the family coverage. Like I said, it's a little bit of a different story here. If we focus on the premiums, you can see that when we're looking at, it's made up of the employee piece and the employer piece. So the employee piece for Plan A especially, is an outlier, right, compared to the other plans on what the contribution is. So, and Plan C is higher than most other plans. But again, it's kind of a strategy that was in place. So I guess it's kind of a whatever policy you want to have. There, at the time, I think, I'm probably speaking out of turn here, but it depends on where you want to put your money. Some people, they don't want to subsidize dependents. They think they could get their coverage on their own health plan or whatever the case may be. So anyway, I'll stop there, but I think that's why the contributions are so much higher there in Plan A and C, and that contribution amount is really what kind of drives the next couple slides. All right, so when we get to the allowed cost, Plan C and Plan A are a little bit lower. Plan A is right in the middle. So again, this is more a function of the risk that's in the plan. Then I'll flip over to the richness. So there has been improvements in Plan A and Plan C. So Plan A was way at the bottom, but it's getting closer to the rest of the benchmark plans. And Plan C has also seen improvement, but again, it's on the lower end of the spectrum there. Any questions?
I have a question I don't think you can probably answer, but I'll ask anyway. So as I look at the richness, it looks as though specifically for the family, both A and C are decidedly on the low end of the spectrum. If I go back to the annual report that Jennifer was covering, Director Flory was covering earlier, the enrollment by tier, obviously employee only being the highest and employee plus family among the lowest. I think that likely a direct correlation between the two there. Something to keep in mind as we move forward, not suggesting we take action one way or another, but just something to look at. Any other questions, Commissioner Schmidt?
Thank you, Mr. Chairman. Well, this isn't directly related to the slides that you presented, but I would like to bring up a topic that I think we've had some previous conversations about, as long as we're talking about the plan richness and the plan things. This is in regard to the Valley Hope and residential treatment facility exclusion issues that I've brought up before. And I know that had some meetings and I wanted to report back, again, just in the richness of the plan and what we cover and what we don't cover. So the insurance, and may or may not, I'll back up a little bit, may or may not remember, Valley Hope has a couple of facilities. I don't know how many exactly. Norton is one of them, but they have some facilities here in Kansas for substance use disorder. And the state employee health plan does not pay for room and board with when insured from the state employee health plan goes into Valley Hope, that we don't pay for room and board. We'll pay for the treatment modalities, but not for the room and board. So we, the insurance department surveyed, we thought it'd be a good idea to give you a comparison and to survey some things. And so I wanted to report to you. I'm not asking for an action item today, but what I am asking is that for more research be done, and that at the next meeting, maybe we be able to put this on the topics to discuss, or to get more info. If you want more information that we haven't looked at yet, we would entertain that. The insurance department staff surveyed our TPAs and our third-party administrators, Blue Cross Blue Shield of Kansas and Aetna, regarding the coverage of the room and board under large group policies. Each carrier indicated that they provide coverage for room and board in a residential treatment facility. So we would clearly be the outlier here. We also looked at, we surveyed our surrounding states. Amazingly, the same 5 states that you surveyed, we surveyed for that. And again, the coverage was largely provided for in the residential, for the residential treatment centers. So instead of looking at the benchmark in, and I can appreciate why you look at it this way, but instead of looking at it purely in the financial terms, it might have been helpful to look at, for you to look at the benefits and the exclusions as well, and what those translate to in the overall spending of the individuals. But I know that I know that the CMS came in and did a market conduct examination of the state employee health plan. I think it was concluded in 2021 and 2022. And it appears that the remedy, there was a failure to achieve parity with the facility type in that market conduct examination. But a decision was made effective in January 2020 to exclude skilled nursing and residential treatment for the mental health SUD conditions. So what that means is that if you would have an employee, this is what I think this means, correct me if I'm wrong, but if you would have an employee have a stroke and need to go to a rehabilitation center to regain functions after a stroke, they would be a state employee on the state employee health plan. What the decision that was made in January of 2020, not by HCC, was that we won't cover room and board for that, so that we would not be in violation of MAPIA, of mental health parity. So we were so adamant that we wouldn't cover it for SUD that we took that benefit away from our state employees. I did not know this. I don't recall that decision was brought to the HCC for consideration. I know, Mr. Chairman, you weren't here during that time. I'm fairly certain I would have remembered that type of discussion because I feel very strongly about it, obviously. So I would respectfully request that the commissioners, that the HCC be provided information about how that particular decision was made by staff, and did the TPAs or the consultant, which would have been Siegel at the time, did you provide any guidance or recommendations? I'm very concerned about how these, how this decision was made to update the summary plan description, and how was that communicated? How often are those documents reviewed? And is that jointly with Aetna and Blue Cross Blue Shield of Kansas? And do we consult with outside counsel? ultimately, the decision to include or exclude benefits is significant, and I believe that that is our responsibility. And I think it deserves greater transparency and oversight by the HCC. So I look forward to continuing those discussions. I can certainly, I have forwarded these questions to Jennifer already, to Director Flory already, and I would like to be able to have that put on the discussion for the next meeting. I just, again, I have very strong feelings about that, and the fact that instead of doing what I think would have been the right thing to cover, to remedy the situation of the MAPIA situation, to cover it instead of taking away room and board for rehabilitation. Let me clarify that and say that if you remain in the hospital, we pay for the room and board, but the minute you go to a rehab facility, we don't pay for that. And I really can't believe we haven't had more complaints about that if that's what we're doing, if that's truly what we're doing. So that's my hope. And when we get to other items, I have another one for the next meeting. Just
right.
fair warning. Anyway, thank you, Mr. Chairman, for indulging me. I do appreciate it, but I do think these are important things that the HCC should be a part of the process.
Very good. Thank you very much for your comments. As noted, you did send the questions to Director Flory last night. I was CC'd on that in full transparency. So we'll make sure that we have those reflected accurately in the minutes. I want to, and I'm picking on words here, and I might be overly sensitive. I think there was a comment that figure out why the staff made the decision that they did. I want to determine if the staff by themselves made that determination or if there was consultation with anybody else. I just want to clarify that statement for the record.
And I'm sorry, I did go on and say, what did they consult with consultants, outside consultants, but I know HCC was not consulted.
Fair enough. I just want to make sure we're clear on that point.
No, I agree. And if I've said that, I did go on and say the other part of that, but I definitely, that's what that is what I'm looking for.
But yeah, I think we understand the spirit of the request, and we'll certainly
Sure.
take the request seriously. We will dig into that, and we'll get all the historical information and reference documents for the commission, and we will have that included in the next meeting. We will include that as appendix material, but at your request, I can certainly add discussion. I want to make sure that the discussion item will read residential treatment facilities and not one specific provider.
Yes.
Although, so I think you're on board with that. Just want to make sure we're clear again for the record.
Absolutely.
So we will add that as a follow-up for the next meeting and a discussion topic. I believe one other request that came about this was to circle back just for the next meeting with the richness only slide for employee spouse and employee children. So Siegel, if you can confirm that we can get to that by the next meeting.
Yes. Yep.
Very good.
Absolutely.
Okay, thank you. Any other questions, comments on the benchmark study? Commissioner Kane.
I just wanted to make a comment that thank you for bringing that to the attention, Commissioner Schmidt. I think that's really important that we examine that. So I'm looking forward to that discussion at the next meeting.
Very good. Any other questions or comments on the benchmark study before we move on?
The other slides in the appendix, you're really just kind of going into more detail on the plan design features themselves. So those all get rolled up into an AV or an actuarial value, but you can see if you want to break apart deductibles versus copays versus coinsurance versus, and some of the pharmacy benefits, that's where this is. So, but yeah, we'll move along then if there's no questions.
Actually, Patrick, I'm sorry. Can we, we were at appendix material, right? On the benchmark study.
Yes.
Okay. Is now the appropriate time to circle back to slide 83 on the key findings?
Sure.
I think I want to make sure that we don't lose sight of that.
Yeah. So again, comparing against 2020, the plans have improved on several metrics. So the plan value, we talked about that. That's a function of benefit design enhancements that have been made for Plan A and Plan C. Employee contributions have been held flat over 4 years, I believe. So while your competitors or the regional states, there's been some increases across that. So all those things are contributing to better overall plan richness as compared to the last study. And again, Plan A on the single and family is a richer plan because you have a lower contribution and a higher actuarial value. And then Plan A's actuarial value is pretty close to the average benchmark. The benefit features in the appendix that we saw where the member cost share was a little bit higher included emergency room utilization and filling brand drugs. And Plan C, the reason why their actuarial value is on the high end of the spectrum is because of that HSA contribution. And if you earned more credits, that richness could even be higher. But then the last bullet there is just the family coverage is a different story. So that's lagging behind, and that's mostly due to the contributions and the way the employer funding works for that plan, for that tier.
Commissioner Schmidt.
I do have one more question, or a couple of questions on the slide. I never know which page to tell you, 30 or 109, on the average cost per script retail generic. Yeah. So while I know that the $10, $9, and $12 on the PPO plan doesn't look like, I mean, you know, like, well, from $9 to $12, that's still 20% difference. So I think that's something that we should look at. And then on the average cost per script on the next slide, the retail formulary brand, we are way out of whack with that one. So I think those ought to be which is slide 31 or 110. Those are way
Higher.
different from our competitor or our neighboring.
States, yeah, and it's a function of, especially on the PPO, typically there's a copay structure for that, and the state health plan has a co-insurance.
Right.
So that's why there's a difference there.
And other states don't have that?
They typically use a copay structure for at least for PPOs. For high deductibles, everything's kind of running through the deductible and then co-insurance. But PPO, it's more common to see copays for brand generic.
And that has been a common thing with our plan. We've had a co-insurance plan design since about the year 2000, which has been a more advanced structure than what other states have had. One of the benefits to that is if the drug is of low cost, the member is only paying 20% of that actual cost versus a $10 copay when the drug only costs $3. On the flip side, though, there are some drugs where a member may pay more. But overall, the plan design using coinsurance has been a positive because it didn't require us to make changes to the plan as costs of drugs changed, and it allowed many members to get drugs for less than what they would have paid for a flat copay. So it is different. We are different in being a co-insurance plan. Our pharmacy program with point of sale rebates is very much different than what many of our competitors in other states are. But I can also tell you some of those other states are very envious of the fact that we have the structure we have with those point of sale rebates and the co-insurance design. So there are positives and negatives of both sides of that.
But it looks like that's a big negative for the consumer.
Not necessarily, because if you're taking a generic drug that you're only paying 20% of the cost of it, and that drug only costs $10, then you're going to pay less than if you had a $10 copay.
But the previous slide doesn't bear that out. The previous slide said we're paying 20% more than our surrounding states.
Well, again, we're a
average.
co-insurance plan design, and they may not be.
But I'm saying that, but what you're saying doesn't bear out in the numbers that, I mean, we're paying 20% more on our generics than our neighboring states. I mean, 9 to 12 is 20% more.
Yeah. Well, I would suggest that the co-insurance plan design has served the state very well over the last few years, and versus a flat copay that is more difficult to adjust, and particularly as drug costs are continuing to increase, has been a very positive thing for the state. It reflected in our spend. So yes, our employees pay more, but that also means that our employees have a stake in making the best possible choices, because when they pay less, the state pays less. When they pay more, the state pays more. And with copays, you don't have that. You have a flat copay, so the member doesn't really have an incentive to make the low cost choice.
So when you say it's better for the state, is it better for the employee?
Yes, because when the plan saves money, the employee saves money. So if they pick the low cost product, then they're going to pay a small amount of that low-cost product. If we have a flat copay, what's their incentive to pick the low-cost generic? What's their incentive to pick the lower-cost multi-source brand? There isn't one. If I'm only going to pay $20, I just pay $20 regardless of what it costs. And our plan design was set up so that the employee and the employer share in the cost of that drug, so that those decisions, we encourage our employees to make the low-cost choice when one is available to them.
So if I'm going to interject here. I think we're jumping into a philosophical discussion on incentives and dynamic pricing models and things of that nature. How difficult would it be to look back over time? Because this is valuable data, but it is a point in time, as I understand it. How difficult would it be to look back over time to compare what what this would be relative to the region over like a 10-year time frame, 5-year time frame, understanding that it could fluctuate year to year?
It's tricky because this came from our most recent state employee benefits study, and we haven't actually, in the past, we were looking at more high level things. So this is kind of next level on what somebody actually pays, not just whatever the cost share requirement is. So we don't have this going back, and I don't think it'd be pretty complicated to do.
Okay.
I know a lot of time went into just getting this for 2023. So I could reach out to the team that put it together and see if there's any historical years or what we could do to come up with something. But yeah, I don't think it's not something we have at our fingertips.
Yeah, I just if it's something we're able to do, I think it'd be valuable input. I think we can all agree with the numbers that are on the page right here and what they represent, right? And there's a larger philosophical debate to be had, and a lot of modeling that would go into what that would be for the changes. So I think if it's attainable easily without hundreds of consulting hours, then we could benefit from that. Commissioner Schmidt.
Yes, Mr. Chairman, but I would be interested in more of what Director Flory has been saying about the differences in the plan. If you could either Director Flory or Siegel put that into what the differences are in
The cost sharing?
in the cost sharing and stuff.
Yeah, that's
Because
easy.
I also think that one, and it is a philosophical debate without a doubt, but I also think one of the other thing is when I hear things like well, that when the patient or when our employee has the opportunity to choose a lesser price generic, they're going to do it. Well, there's also the third party in that is the physician and the prescribing. And if the physician says, this is the drug I want you on, and the patient says, I can't afford that, I need the cheap, and that's the difference between the philosophical of what the plan is. I think those are important. I think shouldn't take out the medical care professional in that, because I know that when a patient says that does strike home with the physician, and it may not be the best drug for them, but it's the one that was less expensive. So I'd like that in writing.
Sure.
Thank you.
Yeah, we can definitely get the cost sharing for the different regional plans.
Let's start with that action item as opposed to what I'd requested.
Okay.
Thank you.
And
Mine won't take as many hours.
and yeah, you could change that to say you wanted to change it to a $20 copay. Okay, so that's bringing that $157 down. That cost is going to the plan. So then to make up with that, you have higher contribution. So it is a big balancing act, I think, what everybody's saying. So
Very good.
Thank you.
All right, good discussion. Any other questions or comments? All right, hearing none, we will move on to the financial report, which is tab 6 in your books.
it feels smaller than normal. Let's see if we can zoom in a little bit. All right, so we're here with data through the end of the year, through calendar year 2023. As you may have recalled last time, we talked about large claims and the medical projection being a little bit higher than projected originally. And we had a table there that said basically 2023 through October, we were looking at $13 million more in large claims than we've seen historically. Since then, we've got a report that there was a $4 million claim that most of that's, in this data here, but so continue to have some bad luck when it comes to large claims, and that's really what's driving the financials here. But overall, we're looking at a 2.3% gain on revenue. A lot of that's attributed to higher enrollment from the start of the year to now. On the cost side, really all the other pieces parts, so pharmacy and dental and the ancillary costs, those are all within about $1 million, pretty small percent deltas. It's really that medical where we had a 10% trend in our assumptions and that 5% trend range. So that caused a $5.6 million loss. And when you net it all out, I mean, some of that's headcount too, so we have more lives than we originally projected. But when you get to the bottom line, we have $5 million less than what we originally budgeted. That's how the year ended. Any questions on year to date? So now that we have full year, we came back with our trend slides. So the first slide is looking at enrollment. So you can see we've had that historical decline in enrollment, and then in 2023 we jumped back up, and I believe there's growth from 23 to 24 as well. So see enrollment, and then the medical claims, these are on a per capita basis. Again, we're at 10% in this last year. It's been a little bit of a roller coaster because you had COVID here in the mix, where 2022 you had a decline, and then 21 all those services came back, so you had a double-digit trend. Last year we had a big gain on medical, so there's been quite a bit of fluctuation there. If you average it all out over the 5 years, like an effective trend rate, it was 4.1%, which is pretty close, a little bit under than what we've projected, long term. So flipping over to pharmacy, also a lot of fluctuation here. We had some low trend, and then we came up, last year we were almost at 20%. Had a big loss on pharmacy last year, and now, and this is a big function of the RFP, so you have a lot of savings, enhanced rebate guarantees, discount guarantees, so those are all flowing into the financials. So we're at a 1.5% trend, and again, we were pretty close on our gain loss, so that was all factored into our projection originally. Dental, same situation with COVID, where you had a big decrease and then an uptick when it came back. But dental's typically pretty steady. So the last 2 years have been 2 and 2.7%. Not as much volatility in the dental claims than medical and pharmacy. Won't spend a lot of time here because Jennifer just talked through all the enrollment changes. But again, from our original budget, what was projected at the beginning of the year, we've seen about 450 more lives, so that's 1% growth on the enrollment. And here's our snapshot of the current headcount. So multi-year projection, we've added a year, so we're out to 2028 now. And if you look at the different pieces, it's really the medical trend, those claims that are coming through, that's increasing our baseline, so that flows into those future year projections. So we're seeing an increase in medical claims in the out years as well. There's a slight increase in pharmacy. Again, dental is pretty steady, but we saw a slight increase there. The one thing we added this time to the exhibit, we wanted to go back now that we have 3 years and compared our budget actual. So we're looking at what we originally projected for the budget, the actual, and then the gain loss. Again, it kind of bounces around year to year, but then we wanted to look at it in aggregate over the last 3 year period. So up top, we've got our revenue. Overall, we're about 1.2%. We've had a 1.2% gain, so higher revenue than projected. And then on the expense side, it's about 1% loss. So overall, on our net gain, our net cash flow, we're $2.2 million off from budget actual over those 3 years. So that's 0.1%. So again, a lot of fluctuation, but long-term, the numbers are coming in about where we project. And the funding and reserve section, last time when we're solving for that future funding increase that starts at 2025, It was 6.2%. Those large claims at the end of the year and that increase in medical trend, we're now up to 6.9%. And this last report, we had a sensitivity trend on what happens if there's $1 million gain or loss in the experience period. How does that impact that 6.9 or that future funding increase? So now that we have another year, if you remember last time, the delta between $1 million loss and $1 million gain was like 0.4%. Now it's down to 0.2. And the reason is that we added that extra year. So kind of solving, you have another year to spread those gains and losses out over. So that's the end of the report on what I plan to talk about. I don't know if there's any questions.
Commissioner Schmidt.
Thank you, Mr. Chairman. On page 130, I think it's toward the end. Yeah. I don't understand. Those first three columns are the same as the next three columns. So I'm trying to understand what you're trying to show me there when those numbers are exactly the same.
Well, typically we'd be partially through the year. So that would show your year to date. So let's say we're back in the last report that would have showed January to October.
Right.
Okay. So now we have 2 more months. So we have a full year. So yeah, those sections they should be exactly the same because we have a full year.
Okay, just doesn't seem like that was
We
necessary.
wasted
I
some
was
ink.
looking for the differences and I'm going like, I don't see any, so
Yeah, we
something is
probably could have
wrong
hid
here.
those columns. So that was a little extra, a little repetitive, but yeah, that's the reason. Typically it doesn't show that way.
Okay, thank you. Just only on the year end.
Yes.
Okay, thank you.
Any other questions or comments? Hearing none. Thank you for the report.
Thank you.
All right, commissioners. Before I talk about the next scheduled meeting, I do want to draw your attention to tab 7 in your books, which is appendix material that staff has pulled together, follows from the December meeting. Also an EAC, Employee Advisory Committee report from the August HCC meeting, and some published audits. Specific to the follow-up items on page 136, for the next 3 pages, 136, 37, 38. There was discussion at our last meeting about where we rank relative to our peers for lifetime orthodontic benefits as well as annual max on dental. So the information is provided there. And then on page 137, should the commission decide to make a change to either of those, you can see what the cost would be for 1%, 2.5%, 3.75, and 5% increase specific to orthodontia. I don't want to take any action on that right now, but just as we're building towards the August meeting or the plan design and costing, just want to make sure that we have access to this information if anybody has an opinion on that for down the road. Would note that our next meeting is scheduled for April 9th, 2024. As a reminder, that is a slight deviation from the original schedule, but we did talk about this at the last meeting, so it's been on the books. Any questions or closing comments before we move to adjourn? Commissioner Schmidt.
Thank you, Mr. Chairman. I do have a question on the follow-up section on page 142 and 143 on the member utilization. I have asked for this before, and I just, I would like, I think those are on the member utilization from 2019 to 2023 on the visits, and also the member utilization breakdown on page 143. I would like the unique number of patients, not just the total number of visits, but the unique number of patients that those numbers represent. And then the last thing I have is we received a complaint in through the department that I didn't check on this, but I'm fairly certain we would have, it was a state employee health, a state employee that filed the complaint. We send those on, but this one was very curious to me. This complaint mentioned that the state employee health plan had signed on with a company called Prudence, Prudence.
It's Prudent RX. We don't have a Prudence.
Okay. Did we approve that contract?
We did. That was
Yes.
done at, I believe, the HCC
I
meeting that
wasn't
you were not
there.
here for. Yeah,
Okay,
it was in.
okay. So it looks like there's okay, then I will go back. I'll contact you later about this, and because I think there seems to be an issue with the crediting of co-payments and not that co-payment not coming all the way through the system.
Okay. If you can send the
We can talk
specifics
about it
on to staff,
offline.
we'd.
Yeah,
jump on
I
that.
think we've already sent on, but I didn't know what prudence was. And I was
Prudent
like,
RX.
what is that? Okay, thank you, Mr. Chairman.
Absolutely. Any other commissioners with any other comments or questions? Commissioner Kane.
Would it be acceptable for me to share a quick story about the state health
As long as
plan?
it's not about me.
It's not.
Okay.
So I have a colleague who gave me permission to share, but she received a skincare screening because it was an incentive that we implemented last year. And they diagnosed melanoma and she was successfully treated. And so I just wanted to share that she said without it being an incentive, she wouldn't have gotten a skin cancer screening. So I thought that was a great story.
Yeah, thank you very much. That's, I'm glad there's a happy ending there. So thank you for sharing. Any other questions or comments? Okay, hearing none, I would entertain a motion to adjourn.
So moved.
Motion by Commissioner Schmidt. Is there a second?
Kane, I'll
Commissioner
second.
Kane with a second. All in favor, say aye.
Aye.
Any opposed? We are adjourned. Thank you very much.